Welcome to the ACPOHE Physio at Work podcast. So in this podcast, we're going to shed light on occupational health physiotherapy and the important work that us physiotherapists that work in occupational health undertake in private and in public organizations, in education, like in universities, and also in society as a whole, in shaping the health of Britain. So this is a limited series of 12 episodes, during which time we'll be talking to 12 experts in their field of work. Our first guest today is Andy Barrowcliffe. So as this is our first podcast, the idea is to start the podcast off with a generic question around how you would define your own job. How would you define being a physiotherapist in occupational health?
Well, my role as a occupational health physiotherapist and also as a manager within the organisation. So I look after a team of, I think it's 11 of us now that work across the Midlands and wider sites within the UK. My occupational health physiotherapy, it's interesting because it encompasses a lot more than just your standard physiotherapy model. We are tasked really to help an employee remain at work, which we know is good for mental health, but in a safe capacity. So my role really is to help people either stay at work or return to work in a capacity that's not going to cause them harm, but enable them to still contribute towards business. Yeah.
That's excellent. Now, maybe it'd be useful as well for us to get a little bit of your background. So maybe even start to the point, where were you born? Where do you come from? And what led you up to becoming a physiotherapist in occupational health?
Well, I was born in Coventry. Haven't really gone that far from Coventry, unfortunately, although I always intended to. When you've got the ability, it's weird. You don't tend to actually.
It's a great city. It's a great city, Coventry.
It's an average Midland city. It's got its good parts and it's got its bad parts. But so I initially started out working in waste industry, on landfill site, driving bulldozers, working in a power station, and then
in power stations.
In a power station, we used to take methane gas off the landfill site and produce 8 megawatts of electricity.
All right.
But then I was getting a little bored with that, wanted to travel, have the opportunity to travel. Some of my friends were playing professional rugby at the time. I got chatting with one of the physios and thought, that sounds like a great job. So it wasn't like a lifetime ambition to become a physiotherapist. It was more about a fit into my life at that time. So I went to night school, did a couple of A-levels, applied to university, and then did my physiotherapy degree and travelled nowhere.
Very good. And did you go through NHS rotations first?
Yeah, so I started off working in the NHS for a couple of years, doing your junior stuff.
And for our international viewers, the NHS is the National Health Service here in the UK.
That's correct.
Yeah.
And I started a little private practice on the side, and then I was approached by someone asking me if I wanted to do some part-time work in occupational health. And that's when I ventured into the occupational health world in back end of 2004.
All right, 2004. So we're looking at, 21 years worth of experience there?
Yes, yeah.
Blimey. And in terms of your current job, I think we had a conversation with the company that we both work for and with. And what was the definition? Is a large
Midlands manufacturing-based car manufacturer.
That's right. How long have you worked for this company?
Well, I started working, not directly for them, but for the contract holder, which at the time was Sun Rehabilitation and more recently Health Partners. I've been with them since back in 2004, going into 2005, full-time from 2005.
That's interesting. Yeah. And this is the automotive industry, is that
correct? It is, yeah.
And when you first started working in the automotive industry with Sun Rehab back in the day for this particular large company, what was your role? What were you doing back then?
Well, back then it was primarily a treatment-based reactive service.
All right. So like there would be referrals from management, and you would be seeing them and assessing treatment.
Yeah, we'd very much be a classic what I'm guessing the general public would deem the classic physiotherapy role. They come in, you do some treatment, they'd go out, but there'd be very little interaction with the wider team. In terms of, when I say team, I mean not just the occupational health team, but the sort of safety team, manufacturing, all the rest of it. We didn't have really much interaction in the early days with the team.
Okay. Yeah. So essentially, were people self-referring, or were they referred by managers?
No, they come through from managers.
Yeah.
Yeah. It was a really old-fashioned model where we would assess someone, then comment on their physical capacity, and then you have the traditional nurse-led work health advice service or occupational health advice service, which would then communicate with managers.
So you would be working almost for the nursing service or the medical part of the occupational health service, and then you would report back to them?
Yeah, so quite a disjointed way of working.
Yeah. And would it be the nurse then, or the occupational health advisor or physician that would then write reports back to?
At the time, it would have been a nurse operating in the capacity of an occupational health advisor, which would then eventually put the report out.
All right. Yeah. So almost pure treatment, your end, and then you would report back into the
and very little to no interaction with the wider manufacturing group.
All right. Well, I guess that sets the scene to where it's taken us, man. So in comparison to where you were then when you first started working, to where it's taken you, where we've got to, I guess it's going to be a whole tapestry of different things we can talk about at this point. I can imagine the development from where you started to where you find yourself now has been quite extensive. Am I right in saying that?
Yeah, the service looks absolutely nothing like it did when we started.
What would you say the main differences are now?
The differences are now we try and communication is the big change. Now we take we look at, as a physiotherapy service, we look after all of the musculoskeletal absence or injuries within the company. So someone would be referred by their line manager predominantly, and they will come through to us. We will then assess them and then produce a report regarding fitness for work and put the necessary adjustments in that may be required for them to come back to work if appropriate in a safe manner. We also communicate with the wider manufacturing group. We'll go out into the factory and do line walks to look out for potential musculoskeletal risk factors. As a manager, I analyse all of the data that comes in every month now in terms of the injuries that are coming through, and I'm pleased to say we're doing a good job because the vast majority of the injuries that we see are non-work related. However, when we do get work related, and if we are developing maybe an area where we're getting more than I would expect, then I will then task the group, one of the physios, to go out and do a workplace assessment, to liaise with the manager, to put in recommendations to help not necessarily improve the job, but it might be the fact the person's working out of station, or they're not working to process, or it could be there is a little issue with the job that needs adjusting. So with that communication, we can help people, help make some local changes with maybe involving the ergonomic team if it's like a physical change that needs to be done. Good job.
How does the environment look for someone that's never been into a automotive car industry type of environment? How does it look when you go into the factory? What are we looking at?
Well, it depends. I mean, there are so many different areas of the factory. You've got paint shop where the bodies are sprayed. You've got body in white where the bodies are assembled, which is predominantly an upright cell load operation. I'm trying to put it across so people can understand it, but you're basically picking up parts that are generally quite well presented, and then loading into robots for them to be built. You might have to do using some like big rivet guns, again quite well presented. But then you've got trim and final where it's much more dynamic work, because that's where all the trim's fitted into the car. So there's a lot more dynamic movements for people to get in and fit those parts.
More manual, would you say?
I would say it's more manual, but it's different in terms of more to do with body positions, whereas body in white, where you assemble in the bodies of a car, tends to be more upright, quite a lot of walking between stations, whereas trim and final tends to be a little bit more confined to a smaller station, but a lot more activities inside the car and fitting all the components to the car. So it's a lot more dexterous, I suppose, trim and final. Yeah.
So I took my dad a few years ago. I took my dad into one of the factories, and it totally blew his mind. He comes from an island on the coast of Norway, but he had it in his mind that there was going to be just robots, and then people like working with the robots, and the robots would build a car. And
that is fascinating to watch, though.
Yes, yeah. But would you say it's more humans than robots?
Oh, 100%. I mean, you cannot at this time build a car with all robots. It's far too technical for that. And I think car manufacturing is it's fantastic to watch. It amazes me how it all comes together. The amount of work that goes into delivering the parts at the right time for the right car, because all the models are so different in terms of what the customer has ordered, and how it all gets onto that station in the right sequence is absolutely incredible. Really.
And what type of, so as a physiotherapy service, what type of referrals do you see come through to the clinic, to the service? What type of injuries, what type of musculoskeletal conditions, and more?
Well, again, as I alluded to earlier, most of our referrals are to do with non-work related things like DIY, sport, just general people tweaking their backs when they're just doing normal activities like washing in the morning. So there's no rhyme or reason to the referrals that we get through in terms of specific body parts. And again, within the manufacturing industry, the work, some of the people that maybe feel work is contributing towards injuries. Sometimes it could be, but it can be predominantly for backs, hands, shoulders, because it's a dexterous role where you actually, you are using your upper limb a lot and potentially reaching over, picking up parts and things. So,
lower backs and shoulders and hands, they're best sellers in terms of referral.
I guess so. Not so much lower limb stuff, although again, and it's not just the it's not just work that may be causing injury. We've also got to look at other lifestyle factors like general health, obesity, and lifestyle. Really,
life.
Yeah.
Age.
Some of the plantar fasciitis problems that you get, not necessarily all attributed to work, but we know that people are getting heavier as the years go on, and there's that's why the NHS is really trying to focus on that. And we're focused on it as a company as well, not just in terms of weight loss and things, but just in terms of overall well-being. We're spending a lot of investment on well-being to do, but obviously you are going to get your age-related stuff, your hip replacements, your knee replacements, even some shoulder replacements nowadays, and obviously arthritis affecting the hands.
How would you manage that in a site like the one that you're working in, or in the sites that you're working in? So when people start to develop these, I guess when people come in with hip replacements and knee replacements, we're looking at almost like a level of potential disability. Could you argue, or does it just depend on?
Yeah, I think it depends on the individual to a certain extent, and how an individual responds to treatment, whether they view themselves as disabled, or whether they have got a different mindset where they want to get as much out of their own body as they can. But in terms of work, we would be looking at roles that suit the individual, and we've got a lot of different tasks within within manufacturing that people can do, and therefore we try and match their physical capacity to the appropriate role within manufacturing, and that means going out on the shop floor, working with managers to support someone when they're coming back to work, but not always as a full time, as a change to their employment. Because sometimes they can go back to work that they want to do, and often people do want to go back to that. But we can certainly support them short term or long term with return to work plans
and work adjustments.
Yes, work adjustments. Yeah.
And would it be times where you will look at an employee that might have some chronic underlying conditions that might be impacting on their functional ability, and you look at the job that they have been doing, and you just say, well, I don't think this employee can do this job anymore, and you'll be looking at that person being moved somewhere else.
Yeah, absolutely. And it might be obviously we're going to try to keep people as local as they can, because people have got that social network as well within their work. But sometimes we may look wider we may be into a different block if there's a job that would suit them physically a lot better. But I mean, you talk about chronic conditions. We also screen for mental health when people are coming through, and you can often pick up mental health concerns during the initial assessment. And we have got the luxury where we work with a psych health team, and we can refer laterally for someone to receive some mental health support if they are struggling. I mean, in terms of work, we know from the stuff that Carol Black did all that time ago, which only seems like yesterday, when the Fit Note was produced. We know that work is good for you, and most people want to be at work. So our job's easy, really. We just need to understand how we're going to support that employee back to work in a safe and effective manner. If people don't want to work, often there's another reason for that. It's not necessarily physical. They could have something going on at home, or they're unhappy at work. So that we always dig a little deeper and make sure they get the support they need. Should they need it, should they require it. Yeah.
I find that interesting, because a lot of the time where we see, and I do think, I totally agree, I think physiotherapists that work in occupational health are uniquely positioned to pick up on this fine line sometimes between physical health problems and mental health problems. And it always strikes me as interesting that if someone was to go and present to their GP, that often the management of their problem is to be signed off sick from work, without really delving any deeper in perhaps where the causes to their anxiety or depression or stress actually comes from. If the causes for anxiety, depression, stress, what have you, comes from the home situation, being signed off work,
it's not going to help.
It might be the worst thing for it.
Absolutely. I mean, we're in a really lucky position in the job that we do. We have got resource available, and we can give people the whole package. I mean, so we're not just like the old traditional model of physiotherapy where you just getting someone in for treatment. The first thing we need to understand is which every physiotherapist should do anyway, regardless of where you work, whether it be NHS or in private practice. We need to understand what the trigger for the injury is. Is it sports injury? Is it work? If it's work, we need to get out there and look at the job, work with manufacturing, work with group safety, work with ergonomics if necessary, to really understand how we can make that job better, so that we're not causing any more risk or lowering the risk to the employee. We can also refer into exercise programs, into mental health support. We can look at workplace adaptations. We're in a very privileged position in occupational health, but communication is the key, and being dynamic as well. It's not just about, it's always looking to get better. You can always improve. It's like with COVID, we did a lot of work together with long COVID. You said to me, we're getting these crazy symptoms coming through. We're not sure what they are, because nobody really understood long COVID in the early days. we set the service up to support people coming back to work with long COVID before the NHS. And in fact, the NHS actually gave us a commendation for the work that we did. So, and that's just responding to a challenge. And occupational health is all about responding to challenge. And you never know exactly what that may be. Certainly, COVID came as a complete shock to the whole world, didn't it?
Complete shock, complete surprise to everyone. And I find it interesting because it does suggest that ideally in our job, you want, the broader your competencies are, the broader your knowledge and understanding and experience is in terms of dealing with health problems, I think the more suited you are to an occupational health role. Would you agree or disagree?
Yeah, you need to be a problem solver. You need to use a wide angle lens when you've got when you're talking to an employee to try and understand what the issues are, whether it be work related, home related, mental health related, physical related, age related. There's a whole host of things that can be contributing to someone's current presentation. So it's just trying to understand where they are and then putting the right measures in place to help them recover and be happy at work. We know that if people are happy at work, they generally don't become sick. So by supporting the employee, you're also supporting the business and giving them a good return on their investment.
I think it's useful just to emphasize it, that sometimes when we deal with people who have these certainly the blue flags, where it's there seems to be a relationship problem sometimes at work. Our job is to really encourage good communication between employer and employer.
Absolutely, because if it's a relationship issue with supervision, it's not an occupational health concern really, because it's not a medical issue.
But it becomes it because it sort of washes into our management of that person. We're trying to help them get better from back pain, but really in the core of it sits this conflict.
Absolutely, but that's when the appropriate procedures with HR come in. Or if the employee cannot resolve it just with a simple conversation, which is often all it takes actually. But then it is important to steer them down the appropriate channel before it becomes a potential medical issue. But it might be just, we would put a report out maybe saying that communication needs to occur between the manager and the employee if there is perceived conflict, I suppose, for want of a better word.
It'd be really useful for employee and employer to sit down and have an honest, good conversation about any perceived issues that might be.
But it is important to understand that not all workplace stress is an illness. Everyone, well, not everyone, but a lot of jobs are stressful, but it doesn't necessarily mean people are going to become ill because of that.
No, I find it very interesting. I think it's something that can be quite unique to our situation. It's not something we come across all the time, and I think it'll vary from place to place.
But you're right. It is about having a good subjective assessment, isn't it? So you try and understand the bigger picture, and to just pick a little bit to dig a little bit deeper to understand exactly what's going on, which might not necessarily be related to the presentation that you see. We all know that musculoskeletal presentations do often follow a pattern, whether it be mechanical back pain, whether it be intervertebral disc issue, or even cancer. Normally things follow a pattern, and sometimes you scratch your head and think, actually, can't quite work out what's going on physically. Therefore, what else could it be? And often it can be an external factor that's not apparent when you initiate that conversation with the employee.
Yeah, no, I find it really fascinating. So now people get referred in to the service for a musculoskeletal condition, and that referral normally comes from, is it HR or is it from manager?
No, it would normally be from line management. If someone becomes absent from work, or if someone's carrying an injury they want to be looked at, it's important to get early intervention treatment if possible. Certainly within a couple of days, or a day if it's really acute, because we know that, and the evidence is there, that if you get early intervention, the chances are the advice can go out the employee can get better a lot quicker and resume their normal level of function faster.
And treatment can start earlier as well.
Yeah, absolutely.
What would you say be the ideal pickup from a physiotherapist? From let's say the moment that the injury happens, when is the ideal time for a physiotherapist in occupational health to see that person?
I'm not sure you necessarily need a face-to-face consultation initially for something like we you know that if you've got acute back pain, acute mechanical back pain in particular, you're going to have intense pain for a few days, and often then it will settle down over that week or so with normal movement. So I think just having a conversation with someone, if appropriate, reassuring them that it's nothing serious, and encouraging movement, sending out appropriate exercise to get them moving their back is really effective, actually.
Like almost you would see if you could talk to them as soon as possible over the phone, do an assessment over the phone, and then give some reassurance?
Yeah, absolutely. Because often when people have, well, with any pain really, isn't it? Some people can catastrophize. I'm not saying all people, but some people can catastrophize a little bit and just stop moving. Thinking, you know, that's the end of the world for them. You know, once you've had a bad back, always had a bad back, that sort of scenario, which we know isn't true, but has been bandied around for years. Oh, my back will never be the same. Well, why not? Most injuries get better. Why can't your back get better?
I've been told bed rest by my health professional that I've spoken to.
Yeah, exactly. So it's just giving people, having done a thorough subjective assessment. Obviously, you've got to make sure you pick on your flags, your red flags, in particular from a safety perspective. But once you've cleared your red flags and established that they don't need onward referral, then just giving people the reassurance and the right advice to get moving again and just get back to normal.
Well, what type of approaches do we take in terms of treatment?
Well, we can give them a number of different modalities. We do the traditional sort of manual therapy if it's indicated. We try and work down the evidence base really. So look at what has been what the research tells us is effective management, whatever that may be, whether it be some manual therapy, but generally, obviously we prescribe exercise to help them get better. We're lucky to have physiologists that work with us, exercise physiologists. We can refer into them, but not only just for exercise programs related to injury rehab, but we can also refer into them for things like nutrition advice, sleep clinics. If we look at the overall well-being of the employee, if we feel that someone may benefit from some advice, and if they're keen to explore it. Obviously, it's a consent thing. Someone has got to be wanting to go down that route in terms of improving their lifestyle.
So in terms of physiotherapy treatment, there might be some manual treatment, but also exercise-based treatment. Do you find, and this is totally a leading question because I operate like this most of the time in my own job, do you find that that's quite a heavy part of our job to provide condition-specific home exercise program to allow injuries to recover?
Yeah, and we will send them out on an app and encourage people to do them. Generally, we know that people that do that, comply with an exercise program, do generally get better a lot quicker than people that don't. So
exercise is king.
Yeah,
it is.
Which is not rocket science. We're levers and pulleys. We need to move. We're designed to move.
We are. I think that's a really important message of today's podcast, is how important exercise is in terms of not only maintaining our body, but also in terms of recovering from injuries. And then personally, I will add on some manual treatment to add on to the almost the hierarchy that I set out there.
Yeah.
But I think that's different from physiotherapist to physiotherapist, perhaps. I don't know.
Yeah, maybe. Yeah, that's fair to say. But just trying to follow the evidence really, because if the evidence has been if the research has been done and it's been effective, then we should be trying to go down an evidence-based practice route.
Where are we at with acupuncture?
Yeah, I don't tend to use acupuncture, even though I've got a postgraduate diploma in it. I don't use it too much nowadays, although I think it's still got its place. Again, if you're struggling, if someone's in an acute situation and if you're struggling to do anything else, then sometimes it can be a pain relieving modality. So I think it's got its place, but in terms of, I think active recovery we would probably promote that more.
In terms of prevention and working on with a team, and I think we alluded and spoke a little bit about it initially, but it might be valuable to go over that a little bit more in detail as well. In terms of working with employees and employer in preventative measures, how to reduce the risk of having injuries and musculoskeletal conditions, what type of things are we doing in the sites that we are working?
Yeah, so all the team have some time in their diary to spend on the shop floor, basically going out, looking, observing, walking the lines, talking to employees, and looking for things that have got potential to increase risk of a musculoskeletal injury. Often it's an employee that is not necessarily following the process as it should be completed. So it might be just highlighting to that, to the employee and the supervisor that really they should be undertaking a task in a certain way.
So might you actually go out without a plan to see a specific person, that maybe see someone on the line, you're thinking, actually,
so just going and just keeping your eyes open and keeping your ears open. Your ears can pick up a lot of things, especially if people are using their hands inappropriately when they shouldn't be, and that's something. Personally, I'm very fast to address because we don't want anybody hitting anything with their hands. Sometimes people do follow the line of least resistance, so it's just educating that employee really to reduce the risk of a musculoskeletal disorder further down the line.
So we can be out there and undertake what they call them, line walks.
Yeah.
And I also recall back thinking of some specific programs that we have worked on together. What was the job mapping process that we did some years ago? Can you recall?
Yes. So we designed a tool, red, amber, green tool, not in terms of ergonomic risk. Just like to put it out there because the jobs themselves are okay. But in terms, we looked at body position. So if somebody was required to work above shoulder height, for instance, we would score that job as red. Not that it's a red job in terms of causing danger to a non-injured employee, but we wouldn't want to be putting somebody on that's just come back from like a take-off surgery or they've got a bad shoulder. So we just basically designed that tool by assessing the roles within the organisation to enable supervision to be confident when we're sending people back to work with musculoskeletal adjustments, that they're going to be able to put on a process that it would be safe for the employee.
I thought that was a great project, by the way. And in terms of other, because we have an ergonomic team that works in the sites that we work. How do we work with the ergonomic team?
Well, I mean, we've got a fantastic ergonomic team. I communicate. I meet monthly with the ergonomic manager just to go over things that are coming into the workplace that might be benefit to the employee, but also to look at any areas that we might need further investigation. So we can sort of look at any sort of hotspot that might need ergonomic investment in terms of time and to go out together sometimes to look at the roles. So yeah, it's really a great team relationship we've got.
I think it's useful because there is some overlap there, I think, in our job roles. So in some sites or in some places where there is no ergonomic team, the physiotherapists end up certainly doing part of what now the ergonomic team at the sites that we are working in will be doing. Actually, the occupational health physiotherapist will be potentially doing. Is that correct?
Yeah, that's right. So we could do we could go out and look at a work process, do a workplace assessment, and then if we feel it needs escalating, then pass that over to the ergonomic team to go in, especially if they're looking at maybe facility change in terms of tooling or equipment that may need modifying or replacing.
In the absence of ergonomic team, would that process look different?
It would look different. I think it would just mean that we would be more responsible for a large part of that process.
Yeah.
But it is really nice having that ergonomic team, because it's not just the ergonomics. Then you also work with the safety team and trying to look at any process that may be sort of RIDDOR reportable. So we would get involved in the early stages of RIDDOR potential.
Yeah. What's RIDDOR?
Obviously, if someone's developed a recognised work-related disorder like carpal tunnel syndrome or tenosynovitis, then that would need escalating, basically.
Quite interesting. I wonder how often that happens in real practice, looking a bit wider afield now.
Yeah, and I think from our point of view, obviously, we don't want to cause harm to an employee. We're here to protect the employee and keep them fit for work, which obviously has a benefit to the business because they've got a healthy, fit workforce, giving them a good return on the investment. So it's important that if there is a potential to cause one of those work-related disorders, we need to be out there investigating it and then escalating it through the chain to occupational health physician, ultimately to deem whether it is a likely RIDDOR case.
Yeah.
And then we can learn from that and then put in measures to make sure that doesn't happen again.
Escalate out to the company and allow the company that we work for to learn from
Absolutely,
it.
and we certainly should not be scared of highlighting musculoskeletal risk, because ultimately it's going to benefit everyone, not just the employee, which is obviously the initial most important person because they're the ones that are suffering ultimately. But by recognising these potential RIDDOR, and not just RIDDOR, because some stuff doesn't come under RIDDOR, but it still needs investigating. It's not just because it's potential to be HSE escalated, it's just the fact that we need to be aware of any job that could cause potential harm, and by addressing that and putting the right measures in place, we're reducing the risk for the employee, keeping them happy, they come to work happy, the business is happy because they're not having to cover their absence, and it's a win-win situation. So we should definitely, and we're not, and the company I work for is not scared of or nervous about identifying musculoskeletal risk, because we all understand it is for the best for everyone, business and employee.
It becomes we're part of the improvement process of any organisation that we work in that regard, so I can imagine.
And I think if an employee feels supported, it's like the military, isn't it? If you go into a conflict area, like just certainly during Afghanistan with all the injuries, the soldiers knew that they'd got a really good quality medical service behind them, and it gave them more confidence to do their job properly. And it's just to make this sort of parallel to what we do. Okay, we're not sending people into a conflict zone, but if the employee feels they are supported, and that if they have got a workplace concern, it can be listened to, and if appropriate, because it's not always appropriate, but if it's appropriate, and the investment can be put in to help make that process better.
And then there's no waiting list as well, so you wouldn't need to wait to be seen in the NHS. You can come straight into your physiotherapy service and get competent assessment, treatment, rehabilitation to help you recover.
Yeah, absolutely. To summarise here, what we said at the start, occupational health physiotherapy is so much more than just putting somebody on a couch and doing some manual therapy. It's about the wider picture, and we are lucky that we've got the capacity to work with manufacturing and work with the ergonomic team, work with the safety team, work with the occupational health physicians, work with occupational health advisors, work with the psych health teams. We are lucky that we can address pretty much the whole package when someone comes in to help give them the best opportunity to get better, primarily, to be placed safely and effectively in work, and to keep them happy without being dramatic, but to make their life better. So it is about. So there are no. If the job is done properly, in my opinion, there are no losers with a good quality occupational health physiotherapy service working within a good quality occupational health team.
I think on that note, I think we will probably finish the podcast and this talk here. I mean, do you feel like there's anything that we haven't talked about? Is there anything that you would like to add on to the conversation before we end it?
I think I'm talked out, actually.
I think we've done really
well. There's always something else, isn't there? But watch this space, I suppose, because we're always looking to get better.
We are. So, Andy, thank you so much for doing this, and all the best for the future.
Thank you. Yeah, thank you, Lasse.